Good afternoon, all. I take this opportunity to thank the IPS Tamilnadu chapter, office bearers, the organizing team of this the midterm CME. It was a very nice opportunity for me to come here and speak about this and discuss about this topic in front of this august audience. And I thank the chairpersons for a very kind introduction as well. Thank you. So I will share some of my concerns which we all had. I think several years we have practiced. We have seen probably lakhs and lakhs of people who have depression. And while one person responds to sertraline, another person don't. While one person is okay with escitalopram monotherapy, another person is not. And even within the so-called depression, the presentation is not homogeneous. So while one person is a lot of anxiety symptoms, whereas other person is a lot of somatic symptoms, while other person is probably a lot of even psychotic symptoms or cognitive symptoms. So even within the umbrella term of depression, we have multiple subcategories. And as a result of which, the medications also have a heterogeneous response in this diagnostic group. So with that preface, I will try to say, let's say, what do guidelines actually ask us to do? So guidelines, multiple guidelines, a few I've mentioned, that is NICE or APA or a German guideline. Everything says that for a severe depression, you use a single antidepressant, which is a non-monoamine oxidase inhibitor, as the initial treatment in a case of a severe depressive episode. But why are we talking about polypharmacy now? The reason being is that this is a Hessler study which have been come up in 2018, whose basically is a big meta-analysis, have looked into the cause of the depression. And what he has found is that almost only 1/3 of people respond to the initial antidepressant use, and only 20%, that is 1/5 of them actually remit with 12 to 24 weeks of treatment. This study has been in line with the previous STAR-D trial, which we all know is a very important large multicentric trial, which is nothing but a sequential treatment alternatives to relief from depression study. So it has clearly pointed out that the more the number of episodes or more number of failed acute therapies, the remission rate is going to decrease and the relapse rate is going to increase. So clearly they pointed out that, but each step in their STAR-D trial, the remission rate gradually reduced from 28% to as low as 10% in the fourth step. So is polypharmacy prevalent? I will say yes. It is worldwide, it is prevalent. So antidepressants are by far the most common drug or psychotropic medication to be used in a polypharmacy. A significant amount of psychotropic polypharmacy usually includes antidepressant and antipsychotics. From this study, where there was a clear trend in a 10 years gap, the prescriptions have all increased. Maybe there are multiple reasons to explain. One, whether there were more awareness, people seeking treatment more, or the guidelines have changed. So multiple reasons could explain this polypharmacy trend. What happens in India? India also, we have a similar pattern. This is an IPS multicenter study, which has been published in 2013, where Chennai was one of the center, where this is a unique study where it was done in government medical colleges, private clinics, and private medical colleges as well. So it was much more inclusive about, or I will rather say results are all more in line with the real world practice. So what it has been seen is that escitalopram is the most common drug which is prescribed. Almost 1/6 or 14% had 2 antidepressants for treating depression. So looks like antidepressant polypharmacy is prevalent in our society as well. But what are the concerns of polypharmacy? Multiple concerns are all about the drug-specific adverse effects. You have each drug producing an adverse effect by itself. As a result, it results in its own accumulation of multiple adverse events or drug-drug interactions or associated metabolic issues or cognitive issues or other hospitalization, long-term care. So these are all the concerns of having a polypharmacy. But is this polypharmacy is an advantage? Probably this is an editorial which have came up in American Journal of Psychiatry, which it has helped us to understand psychiatry is a unique discipline, where in the sense that, as said by the previous speaker as well, our diagnoses are evolving. And sometimes our patients have a psychotic presentation, sometimes a mood presentation, and then we have to club and then take the entire natural course and then come to a diagnosis. So our psychiatry diagnoses are so unique that it cannot be compartmentalized like other medical diagnoses. As a result of which, multiple medications of different nature may be there an advantage in psychiatry. So most of us are left with the idea of just starting with an initial antidepressant and then see whether it helps. If it is not helping, we are moving on. So even the psychiatric medications, we all know it got introduced as an antipsychotic, but it became an anxiolytic, it became a mood stabilizer. So what happened is that each medication by itself has multiple benefits in multiple diagnoses. So as a result of which, polypharmacy is much more common in psychiatry and it is more understandable, and people say if used rationally, probably it may help us to handle these complex psychiatric illness much better. So this is one of the guidelines of what amounts to a rational polypharmacy. So the rational polypharmacy, the first thing it should be, it should be an evidence base. So to use this drug along with this drug, we need a proper evidence. Second, it should be relevant for this person and valid for this age group. And we should also be very clear that the adverse reactions of the drug, where the benefits should definitely outweigh the risks. If these three are there, then mostly it is a rational polypharmacy. So what we need is not knowledge, but probably we need wisdom to look for the right choice to use for this person who is coming to our clinic. So in the same line, gradually I'm also explaining about what is called as a treatment-resistant depression. So what happens is that we do see people fail the first antidepressant trial. So there are all those people who have failed one trial are not called treatment resistant. There are various definitions are there. Initially, people were not sure how to define treatment resistant depression. So whether polypharmacy is only for people who have treatment resistant depression, or even in initial treatment, polypharmacy could be used or not. We are not very sure. But now later, gradually people started to define it based on some measurements. So measurements like HAM-D or probably a MADRS scale are probably used to define what is a response and what is a remission. So broadly, the consensus is that a partial response is probably a reduction in symptom scores of 25% to 49% compared to baseline. If there is less than 25% reduction of depression scores when compared to baseline, we call that as no response. So, but whenever there is a treatment resistance, as per the usual algorithm, I think first we need to check whether it is depression, and clinically it is more important whether some other treatment factors are led to this resistance, or what otherwise we call a pseudo resistance when the dose is not adequately given. right? So that is an important part of the definition of the treatment-resistant group. So treatment-resistant depression is very multiple definitions, highly heterogeneous group, but overall people who have failed two or more different antidepressant trials of adequate duration and dose. So even now, there is no any international guidelines on what is an adequate dose and adequate duration. But most of them fall into the suggested duration of 4 to 6 weeks as an adequate duration of antidepressant trial, and a minimum of 2 to 3 weeks in the target dose. So this is the usual model of treatment-resistant depression. The most common model is stage and rush model. There are almost 12 models existent now, but it is still widely prevalent. And for a clinician who sits in a clinical practice, this is much more practical. So where stage 1 is where a failure of one adequate trial of one major class. Stage 2 is where stage 1 resistance plus another trial failure of a different class of antidepressant. Stage 3 is where stage 2 resistance plus a failed TCA trial. Stage 4 is stage 3 resistance plus a failure of monoamine oxidase inhibitor trial, where stage 5 is all of them they are resistant plus a failed course of bilateral ECT. So with this, I am just giving some idea about the neurobiological reasons for which will be very much important to understand the forthcoming slides as well. The first thing is what has come up is an exchange. The serotonin and norepinephrine, we have heard all about this monoaminergic hypothesis of depression, which is the most important theory as of now prevalent. There are certain things which I wanted to emphasize in that to understand how we can actually use a rational polypharmacy. So this is a 5-HT or a serotonin neuron, and this is the norepinephrine neuron. This is a postsynaptic neuron, possibly in hippocampus. So if you see, there is a complex interaction between the serotonin neuron and the norepinephrine neuron. The serotonin neuron, through a GABA interneuron, basically inhibits the norepinephrine activity. So many times, excess of serotonin actually, through this GABA interneuron, it dampens the NE neuron. So this, sometimes people are able to explain this as reduced energy. The core depressive symptoms really become better, cognitive symptoms become better, somatic symptoms become better, but still they continue to have tiredness or amotivation. Right, so this is one of the common symptoms they have. So this is one of the mechanisms which has been proposed, saying that excessive serotonin, though it improves the cognitive symptoms, at the end it also dampens the noradrenaline activity, as a result of which the energy and the fatigue is quite significant. The another thing which is important in the polypharmacy is the alpha-2 adrenergic influence. So if you see, there is something called as an alpha-2 receptor on the noradrenaline cell body, and also a similar alpha-2 receptor in the serotonin terminal. So alpha-2 is basically an autoreceptor. In the sense, you stimulate that alpha-2 receptor, it actually inhibits the release of norepinephrine or serotonin from the terminal. So alpha-2 is an autoreceptor. So anything agonist of alpha-2 basically reduces the release of serotonin and norepinephrine. So this is one of the main mechanisms which has been proposed, where mirtazapine is one of the important adjuvant in the polypharmacy, where it antagonizes the alpha-2 adrenergic receptors. The another important thing is we would have heard this combination now and then. Right. So what the combination of venlafaxine and mirtazapine. So what happens, this combination is a combination which has been tried even in trials, where venlafaxine basically increases non-epinephrine availability in the synapse. The mirtazapine basically blocks the alpha-2 autoreceptor. So many people who are not improving with venlafaxine monotherapy start to improve after addition of mirtazapine. So there are a lot of case series which has been published on this. At the same time, there are also equal evidence in double-blind and single-blind studies that it is not a great combination as well. But this combination has given us some idea about what may be the reason why these two compounds have been combined. Similarly, bupropion is one of the common adjuvant which has been used in antidepressant polypharmacy. So initially it was thought to be an norepinephrine transport blocker and also a serotonin transporter blocker. But later studies have shown that that is not the main mechanism by itself. So bupropion reduces the alpha-2 autoreceptor activation. Thereby, when it basically gets desensitized, that's when the norepinephrine transmission becomes better. So bupropion, by this mechanism, has been well known to be a good adjuvant to an existing antidepressant. So with this, we will come to the clinical, what are the things we need to think about. So a person has failed initial antidepressant trial, or has a partial response to an initial antidepressant trial which is used as a monotherapy. So we have to think about whether we have to switch or whether we have to augment. So switching is an option. So pooled data from various clinical trials have said that if you switch from an SSRI to a non-SSRI, another class of an antidepressant, that is a non-SSRI antidepressant, the chances of improvement is better. So in that case, these studies of pooled data have found switching from an SSRI to a bupropion or a mirtazapine or a venlafaxine has an added advantage of little better remission and response rate. This is I've taken from the CanMat guidelines 2016, which is a Canadian group of guidelines for mood disorders, which has pooled various meta-analysis and found out what drug may be superior to another drug. So very interestingly, when probably fluoxetine, fluoxamine, paroxetine are not working, escitalopram may be another little better superior efficacy. Similarly, when SSRIs are not working, mirtazapine probably has a better, little superior efficacy. When fluoxetine, paroxetine don't work, sertraline also has a little better efficacy. Similarly, venlafaxine also. So overall, what I'm trying to say is escitalopram, sertraline, venlafaxine are good options to try as the second antidepressant when the first primary SSRI trial fails. So now, but on the contrary, there are also saying that switching don't work. There are a trial from the study trial, which is a famous trial where there are 7 switch options, bar augmentation options in people who didn't achieve remission with citalopram. The 3 augmentation approaches were bupropion, buspirone, and cognitive therapy. So what it has shown is that the patients who have been added on bupropion had a much better remission when compared to switching to bupropion. So this trial says that probably augmentation may be a better thing rather than switching to a second mood trial. So sometimes what we have to look at this combination or thing is that whether two drugs, two adverse effects, whether that they will discontinue much earlier is one of the always a concern when a combination is used. So, and there are two more few trials of also supporting augmentation. In the sense, these two data which I'm presenting are two meta-analysis which have critiqued switching as an option. So what they have said is switching antidepressant monotherapy who are in people who are non-responders was not effective when compared to sticking to the initial antidepressant. So they are saying that switching does not make a big difference. Okay, and similarly, there are people who have not responded to the standard dose. You, instead of 1 or 2 months of treatment, you wait for 3 months and see whether the person is improving in the next month. The meta-analysis have also shown that if you are not improving in the 2 months, waiting for 1 more month with the same antidepressant is also not going to be useful. Okay, so so there are certain things which we can think about when to switch, when to augment. So probably we can think about a switch if this is a first trial, first initial antidepressant trial has failed. If there was a very poor tolerability to the initial antidepressant, if there is no response to the initial antidepressant, we have enough time to wait, less severe, less function, and preference to switch by the patient. But if you will think about an augmentation, when there are 2 or more failed trials, when there is a good tolerability to initial antidepressant, and there is only a partial response to the initial antidepressant, but you have less time to wait. The severity is too high, so you cannot wait for a new trial. And probably residual symptoms are there even with initial antidepressant, and if the patient prefers to go for an augmentation. So I will come to the rational option 1, that is combination antidepressants to a non-class. This is a trial which is a meta-analysis of 39 trials which have compiled 6,751 patients, which looked into whether a person has been, for the initial episode, a combination is better or a monotherapy is better. This study, this is a forest plot which basically tries to say if the effect size falls on this side, it favors a combination, whereas if the effect size falls on this side, it favors the monotherapy. This meta-analysis have clearly proven that combination is much better when compared to monotherapy in treatment of antidepressant. Then the sub-analysis was made on looking at the trials where SSRI plus mirtazapine was there, where it was in 18 RCTs were pooled together, which also showed that a combination of mirtazapine with SSRI is much better in reducing the depression scores when compared to monotherapy. And also, when they looked into further analysis, there are 2 types of analysis in the mirtazapine, where a combination, even without knowing the responder status, so as a first line treatment itself is a combination. There also it showed mirtazapine combination is better. Then they did the sub-analysis of the non-responders. So when it is augmented. So when it was augmented also, mirtazapine plus SSRI, it favored this combination. Similarly, SSRI with bupropion actually showed significant difference as an augmentative agent, but not as a combination agent. So mirtazapine as a combination agent was very effective, whereas bupropion was effective only in those who had not responded to the first trial, and bupropion is added more as an augmentative agent. Whereas mirtazapine as a combination and augmentative agent, it was much more better. Now coming to rational option 2, which is atypical antipsychotics. Atypical antipsychotics, multiple actions, multiple mechanisms. So it acts on the alpha-2 autoreceptor, as we spoke about. It activates the 5-HT1A, which is agonism, which is one of the important thing for a vilazodone and its rapid improvement with ketamine. All those are all involved with this 5-HT1A receptor, 5-HT7 antagonism, and partial D2 agonism. So there are multiple, this is an important network meta-analysis which have come up in JAMA 2022. Network meta-analysis gives us an idea. So there are, all drugs may not be compared in a head-to-head comparison. So network meta-analysis has an advantage. Even if there is no head-to-head comparisons available, this statistical technique tries to compare even drugs which have not been actually compared in a head-to-head comparison. So here, where multiple drugs like aripiprazole, brexpiprazole, cariprazine, olanzapine, fluoxetine, quetiapine, risperidone, and ziprasidone has been noted. So in this, aripiprazole and quetiapine are the two most well-studied AAs. Aripiprazole in a dose range of 10 milligram, but as less from 2 milligram to 20 milligram has been effective as an augmentative agent. And whereas quetiapine approximately from 100 to 250 milligram of quetiapine has shown to have, as a combination augmentative agent, it has shown to reduce the depressive scores. And added, quetiapine, because of its sedative property, also helps with insomnia and the anxiety symptoms as well. So olanzapine augmentation with fluoxetine also have shown a similar high thing. So brexpiprazole is a recent FDA-approved adjuvant treatment based on 3 trials, which have also shown as a good augmentative agent, and cariprazine from 1.5 to 3 milligram. But we should also keep in mind the recent drugs like brexpiprazole, cariprazine are not so tested. It is not tested for more than 8 weeks. Whereas all other drugs like quetiapine, aripiprazole, risperidone, the trials are much longer. Whereas this is a much more short-term trial. So more studies may be required. Right? So rational option 3, we have lithium. There are a lot of studies on lithium. Lithium has been gold standard as an augmentative agent who have poor response to primary SSRI. There are almost 9 to 11 randomized control trials which have shown that lithium as an augmentative agent effectively improves depression scores when added to the SSRI. So additionally, lithium also has significant reduction in suicidal attempts in TRD when given lithium. So lithium in combination with TCA or SSRI or any other antidepressant in a dosage range of 300 to 1200 based on serum lithium with a duration of 1 to 12 weeks appears to be more effective. And ironically, very interestingly, the response with lithium happens within the first 3 weeks. So initial response happens with, early response happens with lithium, which has been shown with trials which looked into lithium augmentation within 3 weeks. The NICE guidelines but says it is not so much happy with lithium, whereas the World Federation of Society of Biological Psychiatry in fact favors lithium as the primary augmentative agent and antipsychotics as a second-line alternative. Lamotrigine is one of the another option, but time and again, lot of trials have now accumulated to show it is not an effective augmentative agent. Next is the thyroxine hormone, T3. So T3 is twice likely to respond as an augmentative agent. And if you can see up, the STAR-D trial rates T3 as equivalent to lithium. So in its efficacy measures, but there are trials where it is used as an augmentative agent with TCAs, the response were much better. But with an SSRI, it was not so much well. And it also, if they are used in women, they had a better response. And also, if they have a lower baseline thyroid function, those are also the same people who respond well to T3 augmentation. Next is stimulants. So we have D2 receptors. So the D2 DA receptors also have an influence on the 5-HT release. So D2 agonist basically increases the firing of serotonin. So D2 agonism is one of the important mechanism. So There are potential benefits of lis-dexamfetamine and modafinil, which has been shown to increase the dopamine secretion in the D2 receptors, and thereby there is good improvement in the depressive symptoms when used as an augmentative agent. Another option is a recent one is the ketamine. So ketamine with its NMDA has been used as an augmentative agent, which has also shown that it is effective in reducing the depressive scores. Ketamine is a rapid antidepressant, right? Rapid acting antidepressant. So things happen within few days. So its anti-suicidal effect has been, even with a single dosing, it reduces so fast. So ketamine is one of an important, ketamine infusions have been one of the important augmentative agent. Recently, esketamine intranasal spray have been FDA approved, where it is used along as an augmentative agent. So then now we have a lot of things in our basket. So what to choose? So there are lithium, antipsychotics, multiple things. What to choose when a person is not improving? So this is one interesting trial which grouped into multiple arms and has looked into various comparison groups. So there are two terms over here called NNT, which is number need to treat, and NNH is number need to harm. So number need to treat is nothing but it's the average number of patients you need to treat for one patient to improve. So if, let's say, NNT is 10, it means you have to treat 10 patients to show benefit in one patient. If the NNT is 30, it means you have to treat 30 patients to produce benefit in one patient. So higher the NNT, the efficacy is lower. Right? The number need to harm, the reverse, where it's the number of average number of patients you need to have an adverse event. Okay, so basically if the NNH is lesser, it is they are more tolerable. So a drug, we want a drug which has a lower NNT and a higher NNH. So that is a better drug for things. So when they compare this, if the SGAs are definitely more effective than placebo as an augmentative agent, but their NNT starts is at 11. Whereas when comparably the esketamine and lithium are basically a lesser NNT when compared to the SGAs, suggesting that the lithium and esketamine are much more efficacious agent when compared to second generation antipsychotics. Among the second generation antipsychotics, aripiprazole, olanzapine fluoxetine, risperidone, and ziprasidone have better efficacy when compared to other antipsychotics. Ultimately, the risk-benefit ratio favors lithium more when compared to SGA and esketamine. So overall, when you take the tolerability profile and everything, lithium looks like is a much more better augmentative agent, both in terms of an efficacy and in terms of tolerability when compared to other agents. So this is a recommendation of the CanMat, where they have used various first line, or probably they have ranked antipsychotics as the first one, whereas the other drugs like bupropion, lithium, modafinil, T3, everything comes as the second line, and all others fall others. Whereas the ketamine is an experimental only in research setting. Other options, as we all know that there are multiple options apart from this polypharmacy, and neuromodulation techniques like RTMS, TDCS, the best known ECT are all available as well. So what are examples of an irrational polypharmacy after knowing all this? Is if let's say you are switching from a venlafaxine to a duloxetine, which both have a same mechanism, probably it is an irrational polypharmacy. Probably when a person has failed quetiapine, probably switching over to mirtazapine is also a bad option because both have the same mechanism. And similarly, if a person has failed aripiprazole, then switching over to pramipexole or buspirone also is a bad option. So adding an SSRI with an SNRI is also not a good option. So we know this MAOA interaction, so it's a bad option. Lithium probably within a person with hypothyroidism may not be the first choice. So this is, to sum up, this is what has been told in the CANMAT guidelines. So there is a first-line antidepressant. If they have no improvement in 2 to 4 weeks, consider switch versus adjuvant. Probably it is more towards a switch to a superior efficacy or an adjuvant molecule. Then look for the response. If they are doing well, continue the treatment. Along with, if they have symptom remitted, maintain them for 6 to 9 months, and then probably work on with gradual tapering. So to conclude, TRD definition is very heterogeneous and thereby results in various prevalence rates, but generally accepted to be 30%. Rational will be required in a significant percentage to reduce this disease burden. When considering rational polypharmacy, think about pharmacodynamic, pharmacokinetic advantage, their patient's adherence, the coexisting psychiatric medical comorbidities, the symptom dimensions before selecting the rational polypharmacy compound. Strategies which are rational and evidence-backed are combination of a non-class antidepressant like mirtazapine or bupropion, or an atypical antipsychotic like aripiprazole, risperidone, quetiapine, or lithium, modafinil, while esketamine is probably more in a research setting. But which among this is the best? We still need more data. Currently, there is inconsistent evidence on which may be the best strategy, but looks like augmentation may be a better strategy when compared to switching. And literature is evolving on other newer treatments like neuromodulation, which is also we have as an effective adjuvant. And at the end, we have to credit the ECT. When nothing works, this is a consistent player. So almost even in TRD, 50 to 70% efficacy when all other fails. So that's all. Thank you.